The SPRINT study was a randomized trial which compares lenalidomide as an experimental arm versus a control arm which consisted of single monotherapy investigator choice. There were 5 drugs. And it was based on the practice we used in Europe in the 2008 where the study was designed. And the main objective was to compare progression-free survival if lenalidomide really is improving progression-free survival as it has been anticipated from the single-arm studies. So the patient profile was one of the worst patient profile, relapsed refractory mantle cell lymphoma. Generally, the outcome of mantle cell lymphoma patient is improving, but when the patient relapsed or when is found refractory, then the outcome is very poor. So this is a very risk population. We tried to find a way how to improve the outcome. Progression-free survival was the primary objective, and we have clearly demonstrated that the lenalidomide monotherapy significantly improved progression-free survival by decrease of the risk, disease progression or death by almost 40% with a hazard ratio 0.61. And there are some secondary objectives. The overall response rate was found significantly better, 40% versus 11% in the control arm. The CR rate was, the CRs were observed only in the len arm. The duration of response was longer in the lenalidomide arm, 16 months versus 10-month median, but it was not statistically significant. And the overall survival was same in terms of the statistical significance, but there was a median for lenalidomide treated patient 28 months versus 21 months. It means the almost 7 months longer compared to the control arm. But it has to be said that approximately 50% of patients who were treated in the control arm finally crossed over to the lenalidomide. So the study was not designed to pick up the difference in terms of the overall survival benefit. We compared the lenalidomide, the experimental arm, and the control arm, and the major treatment-related adverse events were the hematologic toxicity, neutropenia, thrombocytopenia, there was no significant difference compared to the control arm. In the non-hematological toxicity, there was a slightly higher incidence of the treatment-related adverse event, but only grade 1 and 2. So in terms of the safety, it seemed that the lenalidomide really had a very good safety profile. I think that the main conclusion is quite clear. So you can use lenalidomide based on this solid, robust data and be sure that you can add some improvement and to achieve some improvement in this risky population. I think that hopefully this study will lead to the registration in Europe. In the US, the lenalidomide is already registered for the relapsed refractory mantle cell lymphoma population. And in the future, definitely the lenalidomide will be tested in the combination, so rituximab plus lenalidomide or anti-CD20 antibody plus lenalidomide, or maybe the lenalidomide with some other targeted therapy. I think this is This is why we did the study, to improve the patient outcome. But it all depends, at least in the Europe, when the drug is going to be licensed for this population, for relapsed refractory mantle cell lymphoma. And when it is licensed and reimbursed, it can significantly change. Together with the other modern therapy, they can significantly change the outcome of the relapsed refractory patients.